I'm Dr. Salil Khandwala, Medical Director at Advanced Urogynecology of Michigan. Today we'll talk about the importance of this pudendal nerve block for postoperative pain management after a vaginal surgical procedure. There is a lot of discussion happening nowadays on pain management, and the narcotics have really come under the spotlight. They are used and abused frequently, and they have a lot of their complications, whether it's nausea, vomiting, constipation, worsening pain, dependence, whatever that may be. Our goal now in medicine is to see if we can start relying lesser and lesser on these powerful and potent pain medications which cause significant drug dependence. So pudendal nerve, let's go over a little bit of anatomy. So this is the vertebral column. It ends here, called the lumbar vertebra. This is your tailbone, and this is the tip of that tailbone called the coccyx. This is your pelvic side bone. So what you're seeing is when the nerve comes out, they are the three branches that come from that spinal cord called the S2 nerve, S3, which is the sacral 2, sacral 3, and sacral 4 nerve. They come together and they form what is known as the pudendal nerve. So this nerve is responsible for providing the sensations and the muscular activities to the pelvic floor muscles and the organs. That nerve goes under a ligament and then supplies the organs. So if you look at the vaginal opening right here, so these are the thighs, this is the buttocks, this is the anus, this is the vaginal opening, this is the urethra. So the nerves of the pudendal nerve supply this entire region and therefore help with pain control of this region. The first branch is called the dorsal nerve of the clitoris, which comes up and helps the sensations in this area around the clitoris and the mons pubis. The perineal branch, which comes out here and helps with the perineum, which is this area right here. And then you have what's called the inferior hemorrhoidal nerve or the rectal nerve, which also provides sensations and the muscle activity in this area. So when you look at the pudendal nerve, it mainly supplies this entire area. So this is the half of it. So we look at the full area. This is the whole area. So this is where we do our vaginal surgeries. So the most pain that you notice is in this area. It's not in the mons pubic area, which is where the pubic hair is, or in the groin. Is more in the pelvic area, because the surgery that we now do is entirely done from inside the vagina. And it's almost like an episiotomy, like incision on the outside, but most of it's done on the inside. So if there is any pain, it's going to be in the pain of this particular nerve area distribution. So we use two agents. We use a local anesthetic agent, which lasts a long time, along with a steroid, which makes it even last longer. And we basically identify this particular nerve. And how do we do that? As you can see, the nerve is going below that. Then we put this needle under that, and as the needle goes in, we stimulate the nerve. And when we stimulate the nerve, you can actually see the contraction of the rectal sphincter. When that is seen, we know we are in the right spot, very close to the nerve, and then we put the medication in. And that's done on both the sides. And when we do this, it numbs the nerve for quite some time, for several hours, and that decreases the pain at the vaginal opening. It started initially with obstetrics. When we did not have the epidural, this is how most obstetricians helped with delivery pain, because it's all at the opening of the vagina where the pain was. So we are doing a study to see how do patients do after we do the block. How much pain do they have? And if they have pain, how bad it is? And did they need to take any specific medication for the pain? So this is approved by the Beaumont Institutional Review Board, which is the ethics committee. And the goal is to assess pain after the surgery and maintain a strict log of pain medicines taken after that. And eventually our goal is to compare doing the block versus not doing the block in the future study and see how it helps. But in your case, if you have pain, then you'll be marking on a line, no pain to worse pain. So you just mark wherever you feel like drawing a line, you mark that. And then you can mark at the area where you're having the pain, this being the vagina, this being the groin, this being the inner thigh, this is the lower abdomen. This is the back, this is the upper back, this is one buttocks and the other buttocks, which is the same number. So you mark where the pain is, and then we can gauge what it is. So why are we doing this? Our goal is to see if we can almost minimize to completely eliminate pain after the vaginal surgery for prolapse. And that's really important. Why should anybody be in pain? Because the lesser the pain is, it's better because your muscles are not in a spasm, and therefore your recovery is much better because you have less pain, less spasm, easier to empty the bladder, easier to go for a bowel movement. Also, less pain means less need for narcotics, and narcotics can cause nausea, vomiting, which is not good. I've just done a good prolapse repair surgery. I don't want you to start throwing up, because if you start throwing up, then it can compromise our repair. Same thing, narcotics can cause slowing of the bowel activity and constipation. Now you get constipated and you're straining. Well, that's not good enough either. And there are other side effects of narcotics, especially as I mentioned, long-term dependence. So if we can avoid these narcotics, great. So our goal is that if we do this block and do it correctly, and it's working well for you, can it be that's all that you need, or could you also get away with just something like Motrin or ibuprofen over the counter? You don't need to take anything like a prescribed medication. And that helps not only healthcare, but help you, because now you'll be able to get on your feet and move on and get home much quicker than what you would have otherwise done. So please remember, this is a simple study where you just have to mark on a paper as to if you have pain, and do it only if you have pain. If you don't have pain, just state, I did not have any pain that day. But if you had pain, you mark what is the degree of pain, especially if you're taking a medication more than a simple ibuprofen medication. So this is what we're doing. We're following about 20-25 patients, and we'll see how the result is. And hopefully we'll come up with the right answer so that almost pain can be eliminated after such a surgery. So we know that the surgery is going well. Now if we can control and help the pain, that'll be fantastic. All right. So let me show you how the pudendal nerve and its branches look. So this is the pelvis that we showed you before. So these are the pelvic muscles. As you can see, this dot is where the pudendal nerve is. And as it comes from inside the pelvis, it gives those three branches. The one is the branch that goes towards the clitoris, one is the perineal branch, and the third is called the inferior hemorrhoidal or the rectal branch. So the pudendal nerve essentially supplies this entire pelvic area at the opening, and that is why if we can numb this nerve, we should be able to numb the nerve sensations to the opening, and therefore help with postoperative pain management. I'm now going to show you a brief example of how this is done in a model. So now this is the female pelvis that we're looking at. So this is the bones in the front, which are your hip bones up here, and then the pubic bone in the front, and then this is the tailbone at the back. So we're looking from the bottom. As remember, I mentioned that this is where the pudendal nerve area is, and it gives off those three branches. This is the nerve to the clitoris, this is the nerve to the perineum muscles, and this is the nerve to the rectum, or also called the inferior hemorrhoidal nerve. Now to numb this area, what we do, we have a special contraption where you have this device. So what we do is that pudendal nerve, so let me turn this pelvis around so you can see from the inside. So you see this area right here is where the nerve crosses from behind. So what we now do is we put this thing on top here like this, and we hold it in place like this, and then we put the liquid on top of it and put the water or the local anesthetic through this area and into this spot right here to numb that nerve. So you see where this thread is, and that is potentially where the nerve would be, and that's how we numb it. Once it is numb, the branch that comes like this and around will then be numbed.